Well, let's move on to the last presentation. It relates physical rehabilitation and mental health aspects. Rehabilitation is under research, particularly among the younger age groups. So there is an urgent need to manage impairment and disability in order to obtain the best functional outcomes after immediately surgery in patients with high demand motor tasks. In addition, mental health aspects and changes of body image may have a severe impact of patient quality of life. So it's my pleasure to invite Professor Uta Dirksen, whose commitment as pediatric oncologist in both sarcomas, especially Ewing sarcoma, is worldwide known, and of course doesn't need any additional word. Please, Uta, tell us.
Thank you, Ornella, and hello to everybody. I'm very sorry that I cannot attend the SPAEN meeting in person, although it's just like 2.5 train hours if the German railway goes away from Essen. But we have here still kind of very strict COVID restrictions, and we had some colleagues attending some conferences, and they are now all at home. And so I'm kind of had to hop in, and I'm on duty today. But the young fellows promised me not to call me in the next few minutes. Yeah, it would have been really a pleasure to see you all in person again, but times will change and times will become better. So I was asked to give a presentation on late effects and also on rehab issues. And when I worked on the talk, I came across another talk I gave as the SPAEN meeting in Milano in 2018, and so there I had a talk on like sarcoma subtypes in children's, teens and young adults, and we talked about all these different diseases and also on the treatment the patients have to face with high intense chemo and surgery and Ewing's and osteosarcoma, for example. And this was my last slide. And with this, my talk ended at that time. And I said that late effects are also important. And yeah, and so we kind of 4 years later go into this also a really very important topic. So late effects in sarcoma patients may be caused by different types of the treatment. It's of course the chemotherapy that adds to it, and of course surgery, but also radiotherapy. The malignoma itself may have an impact on our quality of life and well-being after cancer. There might be some genomic aspects, and of course also our environment and also our lifestyle that the patient has after being cured or after end of treatment. And yeah. And usually we have our post-intervention follow-up investigations. The oncologists focus mostly on relapse, and this follow-up usually ends like at 5 years after end of treatment. Then we always force the patients also to see internal medicine people, endocrinologists. There's a radiotherapy follow-up and also a surgery follow-up to look for late toxicities. And there are also programs looking for preventional measures which concerns lifestyle. And what came across us is already 20 years, a paper that was like published 20 years ago, but is unfortunately still true, is that patients after cancer have a poorer outcome and a poor long-term survival. And as you can see from the timeline here, this is not usually, often not the malignancies. In some patients it might be the recurrence, but it's also due to other factors, as we can see here. So recurrence would occur kind of early. Then we have a phase, then we also have second malignancies, but we also have other factors, external factors, cardiac factors, pulmonary factors. So we really need a very good and very long-term follow-up for our patients. And I would like to just give some examples on issues where especially bone sarcoma patients should have an eye on. And we will also talk, of course, on psychosocial issues and prevention, especially for the bone sarcoma patients. So cardiotoxicity is really an important topic to talk about, because most of the bone sarcoma patients get anthracyclines, and we have the anthracycline-induced cardiomyopathy, which may be even increased if the patients get radiotherapy to the mediastinum, or for example, whole lung irradiation, and then they are at risk to get early coronary heart disease, pericarditis, or valve insufficiencies or stenosis. And we know that there's a cumulative dose of anthracyclines that should not be exceeded. However, in also relapse disease, we sometimes tend to re-challenge with anthracyclines because it's a really good drug, and it's very, very important to have a look at these patients later on carefully. And there's an early onset cardiotoxicity. This is like up to 6 months after end of treatment, but there are also late cardiotoxicities that may occur even 10 years after the end of treatment. So it's kind of a need for lifelong cardiology investigations. At least every second or every 5th year you should visit a cardiologist and have a checkup here. And just to show what can happen here, the typical anthracycline-induced cardiomyopathy is you get this large heart. And what is ongoing here is you lose the heart is a muscle, and the muscle cells, the myofibrils, get into apoptosis, so they just disappear. There are vacuoles within the heart muscles, and there's a cell death, and this causes really this cardiomyopathy. And as we said before, the sheer dose of anthracyclines makes a difference, but we also learned that in old days we gave anthracyclines as a push infusion, and now we give it over 4 or 6 hours, because the time of the infusion, if you prolong it, this is better for the heart. Radiotherapy was already mentioned. Young age at diagnosis is a risk factor. Female seems to be a risk factor, and additional cardiac stress. So what do we mean by additional cardiac stress? We have the isometric stress, which gives in a short term a lot of stress to the heart, and this is during pregnancy and also during delivery, so giving birth to the child. This is an enormous cardiac stress, and we always recommend, if we have young women who are fortunately pregnant after cancer, we really recommend to see very regular, and especially just before birth, a cardiologist to make this procedure safe. And also people who go like in fitness studios and do heavy weight training, this is also an isometric cardiac stress, should be either avoided or these people really should see a cardiologist maybe once a year. And what is also important, and some of you got aware on this with all this COVID discussions, because there was this saying that, for example, the BioNTech vaccine may do some affection to the heart, but in fact also every viral infection can affect the heart, can lead to myocarditis, and this can be and this can be just like the last drop in a heart that is already kind of pre-stressed by anthracyclines. And so patients, survivors should really be careful after every viral infection and see whether they really feel fit, and if not in a decent time, should see a cardiologist. Other organs, especially for osteosarcoma patients, hearing loss is a story. So cisplatin and carboplatin are not good for your inner ear, and prior to the treatment and also at the end of treatment, the hearing should be tested. But it's also important to know that there are a lot of antibiotics that can worsen it, and those could also worsen it a few years after treatment. So it's like the same story that we had with the heart. So patients who had platin analoga during the treatment should really be aware of this. Also radiotherapy to the skull involving the ear can induce hearing loss. And what could be the symptoms? It's usually a high frequency hearing loss, and often not really in that area that we use for like general conversations, but some people really need hearing aids because they have also hearing loss in the area where we hear other voices. You may get tinnitus, which is really also a quality of life impairment if you get like these symptoms, and some patients may complain of vertigo. We have fortunately only in a few patients really this below 10 decibel hearing loss, but it's a decent amount of people who get this, and they would need hearing aids thereafter. So we would do an audiogram prior to platin, and prevention is if there's something wrong in the audiogram, this should be paused or changed to carboplatin, and if possible, avoid other ototoxic drugs. Avoid too loud music, because this could also interfere with hearing, and if needed, wear a hearing aid, because this adds to quality of life if you can hear properly. We did in a PAN Care Life consortium, and I will come back to that consortium in the next slide again to explain it a bit more. There we tried to identify also genetic risk for platin-induced ototoxicity, and there were like 14 candidates in the gene identified. However, we would need a larger cohort to really validate these findings. It's kind of the same as Eleni explained. It's always, if you go back into this and you have sometimes disease or situation that could also be induced by multiple issues, you really need a huge database, and we hope you can continue this. And the Plant Care Life Consortium, this already terminated. A lot of papers have been published, and I will just go into two topics of this. Here, patients from the osteosarcoma trials and also Ewing sarcoma trials, or Ewing sarcoma, Ewing 2008 trial were induced, and we had this ototoxicity work package. We have quality of life analysis and also fertility aspects. And concerning the fertility, we were able to kind of publish nice papers on fertility preservation for male patients. I was also part of this group. It was a huge workload because we all had to read like a few hundred papers, and we did a very complicated way of analysis on this. And the frustrating issue really was that there are a lot of papers out on what could cause infertility, but most of these papers had really only very few patients in, or were kind of not well designed. So in the end, we could really only give in a lot of things that we thought would be interesting, only kind of vague results. So we would recommend cryopreservation of sperm in patients who receive alkylating agents, which is like cyclophosphamide, ifosfamide, and especially high-dose chemotherapy, and also in patients who receive platinum, and also in patients who receive cranial radiotherapy. And for all other measures, there were also a lot of moderate or only weak recommendation. And especially, we could not really say, okay, if you get this dose of treatment, you have a really higher risk. We just saw, okay, there might be a risk, and it's kind of easy to cryopreserve sperms, and therefore we would recommend it in these patients. Same is true for female fertility. Here we also analyzed a lot of papers, and we gave here only a strong recommendation for cryopreservation of oocytes only in patients with high dose alkylating agents, high dose chemotherapies and radiotherapy to the ovaries, and not in all other patients. There are really not enough data on the ovarian tissue cryopreservation need in these patients. Okay, next organ is kidneys. We have renal toxicities after chemotherapy, also with platinum derivatives, with ifosfamide, with radiotherapy to the abdomen, but also with other drugs, antibiotics, diuretics, and so on. You may lose phosphorus, bicarbonate, glucose, and potassium, and it's important this renal toxicity can occur during treatment, short after treatment, but also in up to 5 years after end of treatment. So also there's a huge need to really follow up the kidneys, because if you lose, for example, phosphorus, this is also part that we need to build our bones, and then you would get early osteoporosis and other problems. So it's really also important to check up the kidney. Okay, now we come to the big theme of the psychosocial problems and quality of life. There are a lot of psychosocial problems cancer patients may have. So they are afraid, will the cancer come back? Will I be able to go back to work? Will I be able to take care of my family? Will I earn enough money? Will I get a partner? This will have any adverse effects on my marriage or my partnership? So there's really a lot of stress to the patients. And we also know that if this stress is kind of unaddressed, so this anxiety, depression, or other psychosocial distress, these cancer survivors sometimes tend to be unable to follow their healthcare needs, so they don't go to any doctor anymore, and they are unable to go back to normal life. And this has a huge... I'm very sorry, my computer just said goodbye. Okay, there are a lot of studies, and this is really a concerning issue, that return to work is an issue in former sarcoma patients, especially also for example, an American study showed that 34% of cancer survivors and only 15% of other health test persons were like out of work. And there's another study showing that at least more than 5 months after end of treatment, most of the patients feel like unfit to go back to work, and 53 lost their job or gave up within 6 years after end of treatments. And only 31 patients with physical impairment. I mean, and this is what bone sarcoma patients usually suffer from. And 33% of patients with psychological distress continued to work, which is really a very low number, I would say. And there's also a study, these are numbers from United States, but we had like a similar analysis also in Germany, that there's like an annual loss of $16,000 or $1,300 per month in cancer survivor age 21 to 60 years, which is yeah, really an impact for these patients. And I think this is also we need to work on to find better ways to bring these people back to life. Yeah, and one way to work on this is prevention and rehabilitation. At least in Germany, there are huge rehabilitation clinics, also specialized for young patients, and there's and they do like medical checkup, physical checkup, but also do psychosocial support, and also have a specialized team to give some advice what job or work they could do, what could they study, and really to bring these young people back to life. And in bone sarcoma patients, just to follow up on this more in detail, we all know that they all need local treatment, and this could be amputation, this could be rotationplasty or endoprothesis. But like with none of these operations, you have a normal body shape thereafter, and with none of these operations, you have gain back your complete normal functions. So you cannot do every job, you cannot do every sport, and you have an impairment where you have to deal with for the rest of your life. And I would, this is like one example of our former patients. She was a ballet dancer, she had a Ewing sarcoma, she had a rotation plasty, and she really then found another sport. And these are pictures from one of the Paralympic events in Athens. And as you can see, she became really a happy young woman and really got back to life. And how can we achieve this, and what would be an idea? So the program we have, at least here in Germany and also in a lot of other countries, is really to keep the patients active, because activity, sports is a prevention for anxiety and depression and fatigue, and it increases your general activity. It's good for the body image if you can be active. It's a pain prophylaxis and also activates the immune system, so you may even tolerate the chemotherapy better. And we have a program where we also do sports with the patients already parallel to chemotherapy, to really keep them kind of running, to remain, a good, them in a good shape and happy. And this is unfortunately in German, but like this is some sports things we do. And as you can see, here are like two examples how this could look like. This is Vlad, a young patient in our outpatient clinic who's challenged with our sports therapy to play table tennis without a table. And the other is as a young patient on our AYA board, on a ward on a balance board, and really parallel to chemotherapy. And and I would, with this, I would also like to take you on a journey, and I think this is was really kind of cool, and this could maybe be offered also to a broader range of people. So what we did last year was like the first time to go skiing with our TYA patients or TYA patients from Germany. And as you can see here, we had really a huge group of patients with amputations, with large operations, like for example, hemipelvectomy and so on. And they go on mono skis. And this young man here just learned how to use the mono ski. We had a lot of fun. And what was really very important, because this was kind of a setting out of all hospital, although I was with them like as a caring physician. These young people, some of them for the first time stood on their skis. They learned all this, and also jumped over some hurdle, because some of them were kind of afraid to do just the first curve. And this gave a lot of them such a push in their life, and it was really amazing. And so I think, yeah, maybe we should have more of these activities for the patients. We also had some fun, as you can see here, and also played table tennis with a table in the snow. And it was really a great experience. And in the future, we will also do some research parallel to these activities, because as we all know, we need some data how this improves quality of life, or maybe just tools of activity, yeah, to really make this hopefully possible for a lot of patients in the future. Could be skiing, could also be some other, but this group event I think was really kind of cool. And yeah, with this I would like to end that part of the talk, but I also prepared some thank you slides, and I would like to show these in addition, if I may, because SPAEN and also the German Sarcoma Foundation helped us a lot in our activities to bring cancer children and young adolescents and young adults with cancer out of the Ukraine, and this was really a great help for us and also for the patients. And so I would like to show you a bit of our activities. So you can see here a lot of screens of a lot of Zoom meetings. If you look critical at the pictures, you can see that really the background changed. So it was in the beginning, we had like every day between 9 and 11 in the evening Zoom calls on how we should organize all this and how this should go on. And one of the real heroes is here Roman and also Julia. These are physicians from the Ukraine who organized in the country to get the children first to live the former Lemberg and to transport them then to Poland. And from Poland, they were distributed into other European countries. And they did really an enormous job. And it was so, yeah, it was really, I mean, we had this discussion really every night, and then they said, yeah, we had some bombing today here and we had to shelter, and then in the evening you were just talking with them. This was a yeah, very interesting experience. And we really started very early, and in February 24, we really just after the war began to bring out all these young people, and here you can see how many patients came from what areas, and of course most of them from North Ost, and they were distributed to all over Europe. Most patients really went to Germany or to Italy, but also other European countries, and some also to Canada and the United States. Within time, we brought out through this organization more than 1,000 children and young people. In Germany, we had like about 100 coming other ways, and I think also in all other countries. But yeah, it was good to do something in that war. And here's just like the first golden bus that came to Essen. Later on, we had something like a Red Cross organization helping us getting the children out. And so the Polish government provided an ambulance train. This was also the first time I've seen such a fancy train. So you could really put all patients in this train, and they could go. And this train always went into the Ukraine and then back to Poland, and then the patients were brought further with some ambulances. And as you can see here, it's really normal kids who came to us playing with their smartphones as soon as they arrived. And here are just some examples on some bone sarcoma patients. On the top, this is Vladimir. He's 32 years, and he came on other ways with his wife, and they left us their little daughter in Ukraine because they didn't have any flat, and we could organize a flat for him here in Essen so that they could start family life, and he could was able to also get his daughter to Essen, which was very important to him because he had a relapsed sarcoma. And this is Vlad. He has a metastatic sarcoma, a very nice young person that he hopefully now benefits from our proton center. And this is Artem, and in Artem we were able to change the diagnosis. He thought he would have a B-core or synovial sarcoma in the arm, but in fact he had a benign bone sarcoma, and he was really happy to get this news, as you can see here. Yeah, and here's a young patient working with our art therapist. And yeah, so I just thought to also take the opportunity to really say thank you, because it was also due to SPAEN that we could organize all this. Yeah, and with this, I'm happy to take questions also on the other topics.
Thank you very much, Uta, for your exhaustive presentation on rehabilitation issues, and thank you for your strong commitment in bone sarcomas and all the other activities you are doing. Thank you very much. We have a question, online question. It's a bit off topic, but I try. Does pregnancy or growth hormone have effects on the chance of recurrence? Something to consider when preserving fertility? And are there other tumor types where this is seen? It's coming from Caroline Cordoma community.
Yeah. We in the female patients, we usually recommend that they should not become pregnant before, like, they are like 5 years out of treatment. I know some patients who get relapsed parallel to the pregnancy, but I know even more who really just became happy mothers. And at least from the bone sarcoma, osteo and Ewing sarcoma, the answer is no. Yeah, because there's anyway a chance to or a risk to have a relapse, and this could occur under pregnancy. It's a good question, because in pregnancy your immune system is not that strong especially in the beginning, because this avoids this is a way also to keep the pregnancy, but no, we haven't seen that. And growth hormones means like STH, to give this if a child is too small.
Yes.
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 There was always the idea that the growth spurt could have something to do with the development of osteo or even Ewing sarcoma, because as Eleni also showed in one slide, this is the typical sarcoma of adolescents and young adults, where you just have this growth spurt. However, our endocrinologists who treat really a lot of children with growth hormones also did a study on this, and there's not a really clear correlation to this. So there might be other factors. So I think it's safe to provide growth hormones to children who really need that. Because in them, usually there's also a lack of hormones, so you just top up what the body usually would need.
Okay, thank you. Any questions in the room? No. I have a question about coming back to rehabilitation issues. Are there any available guidelines on rehabilitation on all aspects you highlighted?
Yeah, at least in Germany, there are guidelines for rehabilitation, and however, here are also Germany is really a rehab country. We have a lot of rehabilitation clinics, I would say, but we have only a very few where we that we would recommend for bone sarcoma patients, because they are this is I think maybe a problem, because you need extremely good physiotherapists who are not too afraid from of the operation, that the physiotherapist and the physicians who work in this type of rehab clinics would have a close connection also to our surgeons. There's this is something that is really needed, and they also go to our bone tumor conferences and so on. I think this is what is needed.
Okay, thank you.
But I'm not really aware of really international guidelines on this, but this is also something we could work on possibly together with people of these clinics.
Or a consensus paper at least.
Yeah. Yeah.
Okay, thank you. Any other questions? No. Well, just a reflection, many challenges to be faced, a lot of work to done. So I believe that it's crucial to build a stronger bone sarcoma community, empowering the interaction between experts and patient advocates in a systematic manner. And this hopefully could accelerate research progress. Thank you to all our speakers for their excellent presentations, and thank you everyone for joining us. Bye.
Yeah, sorry for my computer.
No, don't worry.